We are a little before time, but how many of you had that sweet outside? Others, you had that sweet? Okay, it's a deadly one. TD Yadav just told me that he has not had that sweet because he was worried about dozing off. Okay, I'm just opening my, yeah, okay, somebody is helping me automatically. Okay. Okay, just go to the, okay. All right, so the topic of bile duct injuries is actually deserves a day-long seminar. In fact, if some of you attended Dr. Vinay Kapoor's meeting, which was in Jaipur last year, he almost did a half a day on bile duct injuries. It was on gallbladder surgery, gallstones. So to do justice to the topic in 1 hour is not easy. What I've tried to do with my co-panelists, of course, is to actually look at real life cases and bring out some of the points. Having said that, we will not discuss prevention of bile duct injuries. We will not discuss surgical detail, techniques of dealing with bile duct injury. So without much further ado, can I just invite the panelists. Dr. Gautam Das is here. I met him. Where is he? Okay, please come on. Dr. Shibajyoti, please come on stage. Is TD Yadav, of course. How can I forget TD? And is that Dr. Sadaf Ali? Yeah, please join us. And Ejaz, is Ejaz here? Dr. Ejaz Bari. So we have this panel, and I'll introduce the panel to you in a minute. If these two statements I put up in my first slide seem a little familiar to the surgeons in the audience, or you can identify with these statements, I think these apply to bile duct injuries, perhaps in a very, very much more closer way than most other surgeries. So as I said, these are real life cases. I must also disclose that I have picked up, I think, out of the 7 or 8 images, 2 from the internet. This is not an exam, but the cases have not been leaked, which means that I have politely declined to give them the details of the cases because I thought there should be some spontaneity. Since we are in Kolkata, there is a lot of debate that we will encourage, the argumentative Indian, but in a civil manner, not the way sometimes it is settled on the Kolkata streets. Audience participation is welcome, but what I thought is that I want to cover 5 cases, certainly 4, so we will restrict audience participation per case to maybe 2 or 3 questions. But I am the boss. So for the next 1 hour, I am the boss. So the idea is that if somebody is rambling, if somebody is taking too much time, something is not coming to the point, I may be a little somewhat rude. And these are the panelists, and these are their introductions. So we have 3 surgeons from parts of the country. There is a local bias in the panel, but we have, of course, people, TD is from Chandigarh, Sadaf is from Srinagar, and the others are from Calcutta. So we have a radiologist who has told me that he is not a vascular radiologist, but you don't need to worry, vascular interventional radiologist, right? You don't need to worry. We're not going to be discussing too much of vascular interventions, but mainly biliary. Okay, now before I go to the case number 1, there are some elephants in the room when we talk of bile duct injuries. And I just want to mention this because very often when we discuss so-called academic topics, I have been told in the past that please do not talk about money, please do not talk about limitations, assume that everything is available and money is not a problem because that is what is academic medicine. In my view, that is not academic medicine. I think it's a silly way to approach academic medicine. So we must remember that we have some real life backgrounders in any discussion on bile duct injury. Most of us work in private medicine. where our patients are paying out of pocket. A bile duct injury is a catastrophic expense. The extent of consent differs from hospital to hospital. So how much surgeons disclose before the procedure is very variable. We have, of course, non-uniform facilities, stand-alone centers coming up, gastroenterology hospitals. The challenge of transfer is a big challenge in India. Anybody who says transfer, of course one should transfer, but that involves lots of challenges. In a lap chole injury, a minor procedure or a procedure which is routine or a minimally invasive procedure is going to become maximally invasive. So there is that shift, and that's the shift which I think is a challenge to management. And finally, of course, this is something I think has been often discussed, and one cannot but repeat it again and again. It's happened to me. It's happened to me twice in my career. You get an injury and the first thought is, what will my colleagues say? How can I hide this? Will it settle on its own? And the reason I mention this is because it often obscures our thinking. So one reason to have algorithmic thinking and discuss it out is to realize that it's happened to others, that others have managed it, and there is a rational way of managing it. So these are some introductory remarks. With these introductory remarks, let me go to case number 1. So this is a setting is of a middle-level hospital, a mid-career surgeon, straightforward laparoscopic cholecystectomy, and at the end of the procedure, there's some bile coming from around the porta hepatis. So, Dr. Yadav, you get a call from this surgeon and says, I'm seeing some bile. What do I do?
So, thank you, and thanks everybody for giving me this opportunity. So, if a surgeon calls me, and there are two reasons why bile can be there. One can be.
What are you going to tell him to do?
I will ask him if he can do if he knows that there is bile is purely yellow color, which means either it is from the bile duct or it is from the above the hepatic duct. It is not from the duodenum and it is not from the gallbladder. It can be from the cholecystohepatic duct, which is more discussed.
So color is suggestive of where the bile is coming.
Very good. One
do
of
the
the
other surgeons agree with this color thing? Okay, just please take the mic. Sorry, just can you just...
There would be a little color difference in duodenal injury and the bile from the CBD.
Okay, so you want to add something?
What I would like to do is, if a call comes, I would like to have a virtual perception of it in the present era. If the person could connect me on a WhatsApp video and show the situation over there.
So you will look at the live video,
right,
and try to help.
Try to understand whether it's a bile duct injury.
So what will you tell him? Focus the camera on the porta and show the structures. What are you going to tell the surgeon?
See, the way we make operative videos and recording, I'll ask him to just show me the area that he's operating upon, and what I would try to understand.
So there's a lot of fat often in the porta. I mean, it's not as if you see the bile duct, right? And this is not ICG, and also there's some bile coming, and it's not clearly the cystic duct is often sort of partly retracted after you have clipped it. So this is the common situation.
And mostly in my place, if I am the surgeon and it's my locality.
No, I'm talking of somebody else.
Somebody
we'll come
else,
to that.
I would understand the level of the surgeon who is calling, and accordingly.
Mid-career,
mid-level surgeon, I would not ask him to venture into much.
Okay, so what would you ask him to do? Okay, so let's see it. So what would you ask him to do? So these are some options. One is drain and out. Is that an option? Drain and out. Put a drain and out.
That's an option.
It's an option.
And the distance would
the other surgeons, drain and out is an option.
It depends
Good option.
on the distance.
Okay. How do you position the drain? See, the reason I say this is because when laparoscopically you put a drain, sometimes the drain sort of flips down and is not going to drain the subhepatic area. Any suggestions, TD? How do you ensure that the drain remains there?
So I will. I think before drain, I would also like to know whether he has taken the gallbladder out or not. If gallbladder is not out, we will say that please don't do anything extra. One more important, just before going. So how after the he had cut the cystic duct, which looks like a cystic duct. What is the direction it is falling? Is it parallel to the what we imagine as common bile duct direction, or it is dipping down?
Okay, so
that
you
is
are
very
going to ask
important.
more questions
Yeah,
on where did
so-
he divide, what size clip did he use,
Yeah.
he or she,
Yeah,
and whether he had a window,
Yeah.
the critical window, etc.
Those are little these questions will give me an idea that whether common bile duct has been cut or something else is there. Then
Fair enough. So
Yeah.
else, currently the person is saying I did exactly all this and there's bile coming. So these are some of the options I have put here, drain and out. Any suggestion for dissecting further to look at where the bile is coming from, expose a little more, given the background of the surgeon? Is that advisable?
I don't think so.
You don't think so? Okay. Yeah, so I think,
No, I just differ. Yes, I think if he's doing laparoscopic surgery, I think he should convert and try to see whether this main duct injury or it's any.
okay, so you're saying that it's better to convert at that point. I just want to respond by saying that even if that person converts, what is the possibility that if he has had, let's say, a right duct injury or a main duct injury, he'll be able to do an effective repair? This is going to be a non-dilated system. This is a lap chole for a. So, do you think of that as a problem?
Well, that depends upon the experience of the surgeon. But as you have already mentioned, that is a mid-level hospital, a mid-career surgeon. So I think before venturing into the on-table repair, certain things you should consider first.
So tricky. It's double-edged. To convert is double-edged. Any cholangiograms? I mean, these things get discussed in literature. So ICG, of course, if it's there, maybe ICG. But cholangiogram, any attempt at cholangiogram, TD?
if he can have his facility, there is very important thing. If he has,
No, but where do you put the either
that's
the
what
needle?
I am going to say. If he can identify the opening and if he thinks that he can cannulate, the cholangiogram might help. But usually at this hospital in this area, cholangiogram would be not much benefit to my mind. Putting a drain
Because
nicely,
even in an effort to put
Yeah.
something into the duct,
injury more can
you
be.
may
Yeah.
create more and more problems.
I would add a point that this patient, if before an injury, if he had doubts, all these points would have been valid, doing a cholangiogram and a bailout and converting it. But now that you have started it, the bile is coming already. So I don't think cholangiogram would be a better option, and it might not be a practical option at a mid-level area.
Okay, now before we go ahead, I'll of course go ahead on this case, but what should the surgeon come out and tell the family? Yeah, start, you can start.
Yeah.
Yes, I think the surgeon should be absolutely honest. And
But he has not probably told them before the surgery that something like this can happen.
Yes.
Probably not, likely not.
okay. So I think they may have disclosed in a guarded manner that some injury has occurred, maybe due to some excessive adhesions or something like that. And
Dr. Khandelwal is standing here.
everything
but-
needs to be recorded. That is very, very important from medical legal point of view.
Yeah, I mean, see, look, recording, of course, is the low-hanging fruit, and it has to be done. But I think it's more important to tell the family, because this is going to start a series of events now. So, yeah, TD?
I think it's very important to go and discuss in a guarded manner. Obviously, he will not go and say that I have cut the bile. He can say that there some complication has occurred, which is common, which can happen with any surgeon. And one step I go ahead, that he can then say that I am going to refer to you to a place, and he then connects to the person where he is referring. If he does all these things, then problems will
Yeah,
be.
we'll come to
Yeah.
referral, and but so you tell that you explain to the family that
Yeah.
these things happen.
Happen.
So one of the issues is whether in your consenting you should already be saying that there is a small chance of. We'll come back to that. Dr. Khandelwal, what we'll do is we'll take some comments at the end of the case. Okay, go ahead since you are yeah. Yeah, go ahead.
Referring the patient, I would like to find out whether any other competent surgeon is nearby, or if I can reach there. At the same time, I would like to possible to get a help from someone other colleague. Even in district town, there are many laparoscopic surgeons. So he is nervous. He is a bit, he is
So
skeptical.
call one more surgeon who should probably be.
And if I am say within 1 hour travel.
Yeah,
I
but,
would like
but
to
that
go-
person should be more, a little more experienced. Or you're
At
saying
least-
just in solidarity?
At
Just
least-
in solidarity
yes,
to help?
solidarity.
Okay,
He will
sure.
confirm whether there is bile duct injury or not, or he may help
Okay.
him.
I think we'll just quickly go on. We'll come back to this theme again and again, how to, when to transfer, when to call others. So this person was told, put a drain and get out. Bile was on post-op day 2, there was approximately 200 ml bile. Patient was very well. Very well in the sense, no signs of sepsis. So what would you do now? Let's start with TD.
So, if we do ultrasound, first of all, do a TLC,
Patient is
DLC,
very well, no abdominal tenderness, no
even if
fever.
it is, he is well.
Okay, that's the point. So
Ultrasound,
he's saying
yeah.
that you do an ultrasound irrespective of whether there are signs
Yeah.
of local
And
sepsis.
we do CBC also, we send bile for the culture and
Bile
start.
from drains is, by the way, discouraged by our microbiologists. They
Yeah.
say that there is no point in sending bile from drains.
Bile,
But
bile coming out from drain. Bile, we are not talking of instant bile, which is coming initially, it would have been
okay, so you
non-infective.
can do a culture.
Yeah.
I'm just pointing out that our microbiologist suggests that that's a contaminated bile which may not show the organism.
Yeah.
But ultrasound is well taken.
Ultrasound, complete
So
hemogram,
not
liver
much
function
collection,
test.
50 cc, 30, 40 cc subhepatic collection.
That
So-
if it is draining properly, and my threshold to go one step extra would be more in terms of, because it's like thinking of CT scan. So ultrasound we suggest whether we need CT scan early
So
or not.
ultrasound is showing
So-
a small collection, he's very well.
And if drain is there, drain is inside the collection.
Yeah, there's a small collection. I mean, have you ever seen a bile leak patient without any collection? I mean, there is a
Yes,
small collection.
then it will, I will decide my threshold for CT scan will be low if there is collection in spite of drain.
So you are saying that you do a CT because you believe in your CT more,
Yeah.
or you want to do a CT angio? What is the reason to do a CT? Because it's a straight jump of money and.
So even in the presence of drain, there can be collection which is not draining.
So you
yeah.
use ultrasound as a screening, and then you go to CT for more accuracy.
Yeah.
Okay, I'm just going to Can you comment on that,
I
Ejaz?
would like to look
Yeah,
at
yes,
the
sir.
local facilities and the other surgeon colleagues of that mid-level surgeons who are available in the district. Say it may differ from area to area. District level and Jammu and Kashmir would be different than a mid-level hospital in a metropolis. If there is some availability of HPV, then it's okay. Otherwise, you should refer the patient and let them work up the best of the people.
Okay,
should-
so referral, at this stage, it's a good stage to refer because the patient is stable. But just need your
Thank you so
comment.
much. Good
Ultrasound
afternoon.
versus CT.
Yeah, always the first, the ultrasound is part and parcel. The first screening investigation of choice in terms of radiology. When you are suspecting, there's a bile leak, ultrasound is the best option. Now, it's easily available, and as the patient is just post-op, what we can do a portable ultrasound and see how much and where exactly the collection is, if it is there.
Okay,
If the
so I just want to interrupt you. So ultrasound is pretty good, except that it may underestimate, and if the bowel is getting dilated, you may not see collections in the other abdomen. Is that true?
I was coming
The
to
post-op
that.
period?
I was coming to that. Now, the ultrasound that I was talking about, we do the this is the second day 2. Early morning we do our ultrasound and we put it across the findings to the surgeon. As well as, the second half of the same day, we also ensure we do a repeat ultrasound and see how the collection has increased.
Whether it's changing.
Very same day. the
Second half meaning within 12 hours. Well, I don't know. The drain is draining. So to do twice a day ultrasounds in
terms of the
Vedanta, that would mean Adarsh will have to forego his fees. I don't know. But so twice a day ultrasound would mean a lot of cost again.
No, the issue is, sir, is the patient stable enough? You are not going to do
patient
it.
is stable. Look, if the patient is tachycardic, dilate, distended,
Then we are just
sepsis,
doing one ultrasound
I-
and we just stop over there.
Okay.
If an is required, the call gets to a radiologist, further we'll see
Okay.
what we can
Now,
do. Ultrasound
what
is
next? What next? Ultrasound, no collection, 200 ml. Next, let's proceed to the next days. Still at about 200 to 50 ml, patient is very well. TD?
Then as I said in the beginning, we'll have a baseline. all parameters, that includes CBC and liver function test. And then on our clinical examination, if he remains the same, abdominal examination is very, very important.
Please don't repeat what I am saying.
So,
because I have told you
so
that
then we will wait and watch.
you will wait and
Wait
watch.
and
So
watch.
you expect that this leak will what? Localize or stop?
Yeah, but it is.
You think this could be a cystic duct
it
stump
may-
which will...
May not be cystic duct stump, but it may turn into controlled external biliary fistula. So that,
But
would,
you don't
that
want,
is my aim.
you don't want to right now know what's happening to the bile duct, MRC.
Day 2 usually you don't do.
Okay, so what's your day? What day would you want to do imaging?
So our protocol is we go for HIDA scan. Patient is stable.
Okay,
patient,
so
yeah.
you've opened a new thing now,
Yeah.
HIDA scan.
Yeah.
HIDA scan to see continuity from the liver to the gut. Is that your intention?
That is only intent, and that will decide whether we can
Does
go
the
for.
HIDA show you where is it leaking from?
No. It's not anatomical.
Yeah,
it
but
will,
HIDA is very, very limited availability. And I mean, we have HIDA, we have used HIDA, but I've never found it, except that if it is it's continuous, then maybe it favors a cystic duct stump leak over a transaction of the bile duct, etc.
It tells you that there is no complete transaction,
Okay.
and you can go for endoscopic or even medical sphincterotomy.
Okay.
Straight away. That is
But what if you, so what about MRCP? I'm waiting for somebody to say MRCP.
One thing I just want to point
Yeah.
out here, that we are missing something, that we are just concentrating on the bile duct. Sometimes duodenal injury can have this sort of,
You know, leak patients
Bile
usually will be
in
sicker.
the drain.
Usually will be sicker. I mean, it's very rare to have a
that
duodenal-
we'll have to keep in mind also.
Yeah, sure. I think you should keep everything in mind. The color will look a little different, but usually will be sicker because it's GI contents coming out. MRCP?
We are coming to that. So the first thing that sir has put across about a HIDA scan, I suppose now it has become absolute. Now the other option out here is we are working at a mid-level hospital. I don't suppose we have a nuclear radiology out there as well. And
Mid-level hospital, nuclear radiology?
he told that patient has come to your center.
Okay.
Okay.
No,
The patient has come to the tertiary care center now, right, sir?
Patient has access to MRI, access to ERCP. So you please tell me what you will do.
Sir, sorry, HIDA scan, it's more or less absolute. We don't. I mean,
Yeah,
the issue
obsolete,
is,
okay, let's-
the issue is with HIDA scan, we tend to definitely get, yeah, there is a leak, but what exactly the anatomy part, we won't be able to get it until and unless it gets fused with
Yeah,
SPECT
so
CT.
let's not repeat.
Now,
let's-
the second thing is that we all, I suppose, we as a radiologist, we would go ahead with the MRCP.
MRCP. Okay, wait a minute. Dr.
MRCP
Das, you want to say something? Because,
MRCP
you know,
in a stable
I
patient.
think patient should get a MRCP if it is available, and then it should
okay.
call a
So
gastroenterologist.
MRCP, now the availability of MRCP is reasonable. I'm not saying across the country, but certainly better than a HIDA scan. I can tell you that. Just a question. MRCP in the presence of a small collection, non-dilated system, how good is it? What is it going to tell you? Maybe Ejaz can take it first and then I'll ask Dr. Das.
So we have two options in terms of MRCP. We have a plain MRCP where we can actually see the cholangiogram as a whole, but we might not be able to see an active leak out here. Now we have MRCPs with contrast. The general contrast that we tend to give the gadolinium based, but we have
How does that help in
I'm
this
coming-
setting?
I'm coming to that,
Yeah,
sir.
sure. So I'm just trying to push so
Yes,
that we...
sir. So the MRCP, there are new gadolinium based scan, like multi-hands and all have come, gadobenot, dimeglomine. So these are hepatocyte specific gadolinium based contrast. What happens, sir, when we do a MRCP, normal plain MRCP, we get to know about the cholangiogram as a whole, but we are not able to actually say is there any active leak or not. But definitely if there is any collection, that also, that we can
Does
see
the
on a
gadolinium help for that?
Come
Is it a
again?
dynamic thing, the gadolinium?
gadolinium scans, sir, I'm coming to that, sir.
Yeah. Now, will it show us where is it leaking from? I'm pushing you because we need to move on.
Yes, sir. Now, when we do a plain scan, we come to know about the cholangiogram as a whole and if there is any collection or not, static collection. When we give a contrast, we have different phases, 1, 2, 3.
Yeah.
The arterial, portal venous and the venous phase. Now, at 20 minutes to 30 minutes of scan, we have the hepatobiliary phase, where these hepatocyte specific gadolinium contrast, they get excreted from the hepatocytes into the biliary system, and it is 100% sensitive in terms of biliary leaks.
No, I want to know where it is leaking from. I know there is a leak.
Yes, so we get to know
Can demonstrate that.
that is MRCP
We'll
with
take
contrast, it is
responses,
80%. The site of leak we can come to know with hepatocyte specific gadolinium based enhancement.
We'll take opinions on that. My current opinion is it's not very easy, but if there is experience on that, we'll take it. But Dr. Das, you wanted to add something? Any takers for direct ERCP because there is a bile leak?
If MRCP shows there is a continuity and everything is fine, I will straightforward take patient for the ERCP with a sphincterotomy, with or without stenting.
Okay. I am going to now invite 2 or 3 questions or comments to the discussion that took place up to now. No, but what is this time? We can't have 7 more minutes. This is a 1-hour panel, right? Do we have 7 more minutes? Why is this showing 7 minutes? I'm worried. I couldn't have over. This is supposed to be 1 hour, right? This is supposed to be a half an hour panel because
I think two half an hour session.
It's 45. Yeah, please organizers tell us how long is this panel for because I was told 45 minutes. So why is this showing 6 minutes? I don't know. Okay, you will change. Okay, go ahead. Yeah. We were on direct ERCP as an option.
Once MRCP is shown that the biliary continuity is maintained, take the patient for ERCP and sphincterotomy.
Okay. So a comment.
In the given setting, if the drainage is like 200 ml, so it's a low output kind of a biliary fistula. If the output were a little on the higher side, then in that scenario, probably asking the patient whether the patient is passing colic stools or not would also help us clinically guide some bit.
So colic stools.
Whether there is likely to be complete discontinuity of the duct or not. It just predicts some bit likelihood, the amount of the fistula output, the clinical behavior of the patient, and presence of colic stools. So so
colic stools is a pointer. I don't know how reliable it is, but it's a pointer. I think it's a simple clinical point. Dr. Khandelwal?
Yes, since it is only 200 ml, I am sure the bile is going into the duodenum. It is not a major complete bile duct injury, and such patients usually decrease the output, and within 3 to 4, 5 days it stops. However, the ultrasound is to be done to see whether there is any other.
We are with you on ultrasound. One more comment.
So, with the low output of 200 ml, there is a very high possibility that there may be collection in the abdomen with the bile. And in that scenario,
MR the ultrasound is underestimating the collection.
And MR is not a very good investigation to show a biliary continuity with a fluid collection. So
excellent point. So we have had that experience that there is a bilioma there and it just obscures. This is the last comment on this because I need to go ahead. Yeah.
So 2 things, sir. One, I think in day 2 we will be seeing a colic stool in all the patients. So we cannot depend only upon colic stools on day 2 at least. And the second, in the presence of large collections, is it easy to tell where is it leaking from on MRCP?
So it is not. So that's the point. Others, you want to make a quick point? Yeah.
Yes,
I think he's made a very valid point. If you have a large collection and MRCP fails, left to me, on 2nd, 3rd, 4th day, I won't do anything. But day 5, if the output doesn't come, I'll do an ERC.
Okay. So there was an MRCP done. Here's the MRCP. Ejaz, I'm not going to ask you to read every detail, but so there is a perihepatic fluid there, right?
Yes, there is definitely a perihepatic
and there
fluid.
is the bile duct seems okay. You can see the right left duct. You can see the probably something leaking from the cystic duct. Probably, I mean the collection is around the cystic duct.
Right, sir.
Okay. Any other points? There is no stone in the bile duct.
The CBT looks clear. The main parietic duct also looks clear. We just beside the CBT at the lower aspect.
Okay. So this was a cystic duct leak, yes, and we asked for a ERCP. This is a ERCP picture. But I'm now coming to you, Dr. Das. So cystic duct stump leak. You are doing the ERCP. You demonstrate the leak. Sphincterotomy only, sphincterotomy plus stent, or stent only.
Well, how big is the leak while doing the?
How big is the leak? It's leaking out fairly freely.
Well, while doing the ERCP, if all the contrast is coming out through the cystic duct and the proximal duct.
Just hold the mic close to you. Yeah.
While doing the ERCP, I will do the cholangiogram, and if during the cholangiogram, whatever the contrast I am injecting and coming out through the cystic duct and proximal duct is not filling properly, possibly along with the sphincterotomy, I will do the stenting.
Okay, sphincterotomy plus stent. Suppose there is good flow across also and the leak is small, do you ever
Only
consider a sphincterotomy only?
Only sphincterotomy is enough.
Sphincterotomy only for low volume leaks, sphincterotomy plus stent for high volume leaks, stent only if there is, let's say, some bleeding problem, bleeding disorder or something.
If there is a bleed, then I will again put a stent.
Okay, any comments from the surgeons? Do you always prefer to have a stent or you're okay for sphincterotomy only?
It depends on the medical gastroenterologist's call, but in a stable situation, MRCP and the patient not showing tachycardia, fever, we can wait for a couple of more days.
No, let's not go back. I'm saying now, we have done ERCP. Yeah, there is a danger of post-ERCP pancreatitis. Endoscopists underplay it. 1% is, I think, low. It's significant. It's always mild. Yeah, your comment.
Sir, I think most of our gastroenterologists, as well as we, prefer getting a stent placed in a leak. We are more comfortable getting a stent into the place rather than just a stent.
Okay, others, quick comment.
I absolutely agree, because the healing is much quicker if you put a stent in place. Mere sphincterotomy takes more time. You put a stent in place, and you immediately stop.
Especially if the sphincterotomy is inadequate. Not everybody.
The purpose of putting a stent, that you are afraid that after doing a sphincterotomy, the papilla may get closed. Otherwise, if you have done a liberal sphincterotomy, drainage is good. I don't think stenting is required.
Okay. I just had flagged that issue of preventing post-ERCP pancreatitis. I don't want to discuss it, except to say that it's a real problem. So every time you do a sphincterotomy, we need to be aware that we don't add another problem to an existing problem. I think we'll move on to the next case because, this clock is worrying me. I don't know why now it's showing 10 minutes, but anyway. So case number 2, uneventful lap chole for multiple gallbladder stones. Morning after rounds, this is the term I picked up. You remember that term, morning after? So morning after rounds. Patient is not looking very well, low fever, excessive pain, raat ko neend nahi aaya, pulse rate 98, TD. Hopefully your resident has informed you at 7 a.m. that this is what is happening.
So again, same protocol, ultrasound, no sending home. If it is patient is not on daycare, and ultrasound.
LFTs are done which showed raised transaminases.
LFT is must, and TLC, DLC is also
Have you seen
must.
a subset of patients with whom transaminases jump, ultrasound is normal, and what has actually, I have faced it, what has actually happened is a stone has slipped down into the bile duct and the patient has severe post-op pain. Anybody in the audience?
I have also seen this. So
Oh, lots of hands. I think relatively less documented problem, right, in literature. That immediate post-op, stone slipping down, severe pain, you think there's a leak, but it's actually, so raised transaminases, think of this problem.
Very important point to raise the amylase. Even alkaline phosphatase can be normal. But raised transaminase is very, very
so
important.
here the ultrasound is showing now 400 ml of fluid, subhepatic, perihepatic, so what's next?
Next is take the help of our friend. As I said, all other protocol of conservative management of any collection, starting with some antibiotic broad spectrum.
So there's no drain, huh? There's no drain.
So we have to put a drain. We will ask take
so
a
drain
help of our
or
friend.
relaparoscopy?
Drain is first. So if it is a collection,
So Ejaz, you are asked to put drains. There's fluid all over the abdomen. How will you effectively drain? How many drains? Where would you put the drains?
2-3 drain can be put. If there are collections, we can put one subhepatic, one pelvic, one.
Yeah, but TD, why not do a relaparoscopy? Maybe Sadaf can take this sort of relaparoscopy. Let me complete.
Yeah.
Wash out nicely and put a nice drain. Why rely on an ultrasound drain? Anyway, they put small drains.
See, if conservatively we can have this by putting a drain, so we can avoid one laparoscopy, and we don't know what has happened to the bile duct. So it might be a waste.
No, right now the priority is to get the bile drained.
So if doesn't work, if 48 hours all our pigtail doesn't work, then obviously we have to go for lavage.
Drain first, wait for 48 hours, doesn't work, then relaparoscopy. You want to make any comments on
ultrasound? When we have a fluid in the subhepatic and the perihepatic, majority of the time they are continuous fluid. So what we do is, at the first instance, we try to put in a drain in the subhepatic region, and it also majority of the times drains the perihepatic fluid as well. Now what we do with the pelvic area, already the patient is having signs and symptoms of having high pulse rate and low fever. We can, with a single shot, we can go and take out whatever the pelvic area collection is there. But a single drain in the subhepatic region would be my first, intervention.
No
in terms,
takers for relaparoscopy?
that is the
Okay,
surgeon's
some
call.
comment, oh, there are a lot of takers, okay. Relaparoscopy, are these the relaparoscopy hand? No, no, there are lots of them. So you see, that seems to be a view, that you clean it out well, etc.
Maybe a CT scan in between would be of help for planning the drains.
Okay,
And-
others
and
quick
this is a
comment.
patient where you
I am,
need to
see,
go-
Adarsh, I am respecting your seniority.
I think this is a very serious comment. If you have a post-operative case, ultrasound shows collection, I think a CT scan is absolutely imperative. You cannot totally rely on an ultrasound.
Okay, and a
There
plain
is-
CT, plain
Yes,
CT is
plain
enough.
CT. If there's one message in the entire session is this, please don't rely on your ultrasound. It's a disaster plus.
Agreed.
Okay.
Agreed. Ultrasound. But at the same time, whenever we are putting in a drain, we do a CT guided drain insertion. So at the same sitting, we actually do therapy as well as we do diagnosis. But I would rather suggest we go ahead and do a contrast CT scan rather than a plain scan.
Okay. What if the patient is crashing, Shibajyoti? What if the patient is crashing in front of you? There are some subset of patients who crash. BP going down, tachycardia. What would you
No,
do?
first of all, in such a situation, I would like to put in percutaneous drain, maybe 1 to whatever is required, and then I observe the patient and see how the patient is behaving, and maybe after 1-2 days, I'll
This is for
repeat
the crashing
ultrasonography.
patient, for the crashing patient. Rapid sepsis. Sadaf, any other views?
There is an option of done relaparoscopy and putting in drains.
Yeah.
And but resuscitation and CT scan wouldn't be taking much time. I don't think there would be a patient who would crash so rapidly.
Usually they don't, but if they have had ERCPs and all, you will have a subset who will crash because the ERCPs
So
have.
actually, if the patient is having this first post-op day, this picture, and then rapidly developing, deteriorating, possibly he or she is developing cholangitis. So I think
No, rapid deterioration could be just biliary peritonitis. Could be cholangitis, but could be biliary peritonitis. You're right, you must think cholangitis, but why should they have cholangitis? I mean, so early.
if MRCP is showing any stone in the CBD, then I think I will intervene, but otherwise.
Okay,
yeah,
so I'm just going to move on. So this patient had a relaparoscopy, washout, there was bile near the porta, query bile duct injury by the primary team, and then the patient was transferred. We decided to go ahead with the ERCP. So here's the ERCP. Dr. Das? I mean, I know, I cannot show you detailed ERCPs here, but...
I think there is a clip over the CBD. So
Okay,
or
so will you
possibly
try to
complete-
push a guide wire and see whether you can go into the proximal?
Yeah, many of the times we try to negotiate the guide wire across the stricture. If we are able to do that, many of the times we are lucky because then we can put a smaller size stent across the clip.
But
Most of the time we are.
It fails, but once in a while you can manage to go into the proximal duct, right? But TD now, this is clearly...
Just one point, that MRCP is prerequisite before going, at least we have to see that sub-connection is there before going ERCP.
No, but I just told you there was at relaparoscopy, it was the bile was
Even
coming
if pre-laparoscopy,
from
even
the-
if we have
from
to see the
bile
road
duct-
map.
From the bile duct area. Okay, fair enough.
Sir, I agree.
I think it's not justified to
Fair enough. For
justify
me it
to
is
go.
12,000 rupees and blah, and not very reliable information, so I rather
So
go
if
ahead.
patient develop acute pancreatitis or other complications of ERCP, and it is a wastage of ERCP resource, so that same money will be wasted in ERCP also.
Okay. Now you are getting aggressive.
No, I
you are
suppose
the
sir,
aggressive-
MRCP should be there.
Okay, I'm
MRCP
scared
should be
of
there, sir.
people from Chandigarh.
Sir,
I agree with Dr. Yadav that an MRCP should
MRCP you will do, okay. Quick
Sir,
comment.
Actually, we have gone some time back to a medical gastroenterologist conference, and where the decision was that they will do a ERCP. This is a surgeon's conference. So we all agree that we'll not do.
This is, by the way, surgeon's conference, but an enlightened surgeon's conference.
So we all believe that a surgical definitive treatment of a bile duct injury and bile duct stricture is a better
No,
method. to
are
treat
you
other
suggesting a early repair at this stage?
Not,
We'll come to that point. We'll come to that point. We'll come to early repair later.
Sir,
Yeah.
So the ERP tells us about the distal aspect of the obstruction that is happening. MRCP will help us out in terms of knowing the proximal aspect.
I'm coming to that. So, I'm coming to that, but this is the ERCP, and in this patient, we waited because obviously this is a transaction. I will come to the discussion on early versus late, and this is what we saw with a repeat MRCP now. This is, I think, a few weeks later, 2 weeks later. Anything that you want to try, Dr. Das?
I don't think we have much role if patient.
This was an attempt to look at the proximal duct, so MRCP, and this is what we saw.
If the patient is having any cholangitis or any infection, I will ask my radiologist fellow
To put a PTPD. To put a PTPD if there is cholangitis. So you would not try anything endoscopically. Fair enough. Okay. So upper biliary anatomy, is this adequate MRCP or not is one question. PTPD would be for drainage, but not for getting more anatomical detail. So when you say weight now, okay, we say weight, others, the surgeons and TD. So I now want to bring in this whole issue of early versus late repair. So we are sort of at 4 weeks. Will you repair? Patient is well, reasonably well, come out of the sepsis.
Normally we
lost about 5 kilos of weight.
So normally we don't repair on 4 weeks.
So
we are proponent of delayed repair.
How delayed is delayed?
Usually in a biliary fistula setting where something is coming out from the drain, we wait for minimum 3 months.
3 months?
Yeah. And
Okay.
if there is
What are your endpoints? Yeah, Nilesh.
Yeah.
So I actually was an advocate of early repair. About 4 years back, I gave a talk on early repair. I don't do early repair now, and I think there is enough data. There was a randomized trial published in Annals of Surgery recently where 6 weeks is the minimum.
2021.
Yeah, so 6 weeks is the time to wait. So it gives time for the biliary epithelium to become more healthy and for anastomosis, because here you're going to talk about long-term results.
Yeah.
So, and you also want to know the vascular anatomy and all the other issues which are associated, which may not be possible in the first 1 week or 2 weeks to know everything. So I think if you have a well-controlled external biliary fistula, 6 weeks is the ideal time you should wait for.
6 weeks, yeah, but you'll also look at nutrition,
Yes, of course.
a lot of other
Look at
things.
all the
Yeah.
other-
Okay. Okay. So
If a situation like this where there is just a clip or just complete ligation, so why should we wait for 6 weeks? If the patient is otherwise well, there is no sepsis and there is no collection in the subhepatic places. So
well, if you have done enough early repairs, you may, you know the problems there. What you see from outside is not what is there inside when you actually try to go in and do the repair. The duct is thin, it's not very dilated. So the results, as Nilesh said, the results will be impacted.
Is
You
the
can put a
dilatation-
loop of bowel there.
is the dilatation of the duct is very important.
Yeah, sir.
Sanjay.
He's saying of a complete block. You're saying of a complete block.
Yes, right.
He's talking of a fistula. So don't confuse two things.
Yeah.
See, he started with the
Yeah, but-
external biliary fistula control.
But if your complete block is causing cholangitis, you can even choose to drain and wait the upper biliary tree. So I'm a little confused by the, so this is, so we started it, so that's not even 45 minutes, so go ahead, okay, for some more time, okay, yeah, because, okay, so,
Dr. Sanjay.
okay, this is at 8 weeks now.
Sanjay.
Let's focus on that MRCP.
I think
Ejaz, you want to
we are
read?
missing one point, sorry to interrupt.
Yeah.
But the immediate repair we are missing out that
Immediate
point.
repair,
Yes,
on
immediate,
table
within,
repair.
With not, on table or within 24 hours, 48 hours. We are just missing that. If the patient, if I have...
No, I'm not missing that. I don't think it should be done.
We have come to repair.
No, I have not missed that.
Okay.
I have not missed that. Unless somebody is wanting to say that on day 2 of a patient who has biliary peritonitis, you go in and repair. So 48 hours is not, no.
So Khandelwal sir, if you read the article
Okay,
of
let's
early
not have
repair,
these cross arguments. I said I am the boss and there's limited time. But I will, you have already, sorry, I just need to go back because I am trying to equity, if not equity, yeah.
Just a comment regarding the waiting period in external biliary fistula, because we are not answering the end point. The end point, that is, we wait for the fistula to heal. Rather than telling us 6 weeks, 3 months, I think we should be clear.
For the fistula to heal, yes. But
That's the
remember,
ideal.
there's a subset where the fistula will never heal. So, yeah, Adarsh is sort of, for the first time, Adarsh is requesting me. So,
A biliary stricture, a falling lap colli fistula rarely heals. Because, can I finish?
Yeah.
For two reasons, that's how injuries in lap colli differ from open colli. Because they're associated with a vascular injury the bile duct gets necrosed.
Ischemia.
Ischemia, and second, the clips are there which fall off. 77% of fistulae in data do not close following lab code.
Yes, I completely agree with that. What I meant is we need to have an end point rather than telling it as weeks. So that's the important.
Okay, sure. I think we'll go on to case 3 because there is very limited time. They have suggested to us that, what, 10 minutes, Dr. Sanjay? Okay, 10 minutes. Okay, great. Okay, so case 3, difficult lab coli, lot of bleeding, surgeon reports. Surgeon said there was an anomalous duct and anomalous artery from the papers. Drain showed bile for 1 week, which stopped and was removed. Patient presents with jaundice, itching, fever at 12 weeks, referred. 16 kilo weight loss. And here's the MRCP, TD.
So it's, there is no fistula, as you said it, or there is bile output
There's
also.
no fistula. The drain was removed, there's no fistula.
So there is no fistula and patient
This is an early case, we saw this about 15 years ago. It should probably be put in the cholangiocarcinoma session, but anyway, go ahead.
So first, like basic hydration, antibiotic, broad spectrum.
Please,
PTBD.
You tell us now how we approach.
PTBD I will do, 1 PTBD.
1 PTBD, 2 PTBDs.
1 PTBD in the beginning and wait to see.
Which part?
Left side, usually left. And
Left side because it's easier to park, or
yeah,
is it? Okay.
that is easier, little bit easier to do.
Ejaz, what?
And then see the outcome. And if it is not coming, then probably requesting our friend to put 2 more, because it is all the ducts are separated.
Okay, Ejaz wants to come in.
Sir, we have a hilar, we can't see the confluence of the right and the left duct out here. So always we need to put in 2 drains.
Always?
Majority of the times when we have a hilar injury or a hilar confluence that we cannot see the right and left duct system getting confluent together, we
So
put it.
are we putting the PTBD because we want intraoperative help, or are we putting it to sort of improve liver function? These are 2 different things.
Both, it will help in both.
Sir,
Okay,
it's going to help 3 ways in
I'll
fact.
come there.
It will help us in 3 ways as well. First of all, we are going to put into the right one. We always try to put into the right ductal system first, then the left ductal system, because the amount of the risk for injury to the vascular system is less on the right than on the left. Number 2, apart from this getting drained, we can always get a cholangiogram and see whether we can pass
Okay, so
across.
MRCP can underestimate the sort of structuring. You are right. I think we must remember that
Yes.
MRCP sometimes, but just to get a cholangiogram to puncture all ducts may also be debatable. Okay,
We
but
are
anyway.
doing external drainage. At the same time, when we get a cholangiogram and we find ki yes, we can go through it, then we do an internal drainage at the same sitting or at a,
If your contrast goes across, you can go across, you are welcome to go internally. There are lots of, see the number of clips there, whether you will be able to go across. But my problem sometimes is parking. They cannot park the drain and the drains come out. So you have to manage. A patient walking with 3 PTBDs is not necessarily an easy patient to handle. You want to make a quick point?
I just want to say that before that, properly hydrating and giving antibiotic, then get a CT angio and then go for PTBD. That would be my
Okay, so I have put it up here. So 1 lobe versus 2 lobes, parking space we discussed. Angiogram for what?
CT angio to see the level of injury, because it is here in this case, the association of hepatic artery injury is
Will
about
it change
45 to
your plan of
50%.
treatment?
Very likely it's a very
50%.
bad injury.
Sure, but
Yeah.
will it change your plan of treatment?
Obviously, at least you know that this artery is injured, and you will wait much more than like 1.5 months or 3 months. What we are
So
discussing.
if the artery is injured, you will
Yeah.
wait more.
Yes.
Okay, any responses to that? If others you are. Okay.
The LFT is likely to be very bad.
Yes,
All 3
sure.
systems are disconnected, and I think all 3 systems should be drained prior to surgery to have a good results. And
So
likelihood
you will
of
drain the
vascular
left
injury-
lateral, the segment 4 duct, and the right anterior and posterior.
If you have a good radiological support, they do it for us in our center.
Okay, so you drain as much as you can. Okay, not very easy to do, but fair enough. So just coming to the how would you approach this from a surgical? I said we will not discuss technique. How are you going to access that right anterior and posterior TD?
Right anterior and right posterior, as you have a drain, one that is a PTBD which is there, that tube helps in. Sometimes we put a saline from this side when you are
But
in
you know,
town.
there is liver
And,
there, no? I mean, it's
then
all gone in.
Usually it requires that coring of the right side.
Coring
Make
of the
a
right side.
incision
So
from
some
the right
hepatotomies.
going to
It's,
the left.
I think we'll not go into the detail, but there is on the right side how to
Yeah.
get access, and all these things have been discussed. Access loop?
Access loop, no, but good duct anastomosis is required. She will require at least 2 anastomosis.
Okay, yeah, Adarsh has hand up. If you're going to say straightforward right lobe resection, we will give you the presidentship of the IHPP.
Yes, I'm going to say that.
Sorry. Okay.
We have data to suggest that patients who had bad bismuth E3 or E4 injuries, you follow them up with hepaticojejunostomy, 75% of them have poor results.
But will you do the hepatectomy as the first stage?
Yes.
Any opinions on that?
No, listen, I'm not saying for every patient. A patient for bismuth 4 injury, today our operation of choice is the right hepatectomy and the left hepaticojejunostomy, and I have data to back it.
Yeah, quick response. Yeah, Nilesh is good.
I'll support Dr. Adar's
Okay, if you support, you don't come
So
up, because
actually,
we need some.
the left
Sorry.
anastomosis does not have a stricture. Right anastomosis usually after doing.
No, we know that, but I'm just asking whether you upfront or yeah, Nilesh. Yeah.
No, I think you should wait for a little longer, because sometimes you will get atrophy. And if you get hypertrophy of the left lobe, then it's much easier to justify right. Because these, Bismuth was the first one, Belgiti was the first one to publish his series of 12 or 20 upfront right hepatectomies. Morbidity and mortality are both high. So you should be very careful in trying to know at least the volume. If you're going to do a right hepatectomy, you should have an adequate left lobe volume.
Okay,
so you can do a right portal vein embolization and then do it.
Quick, Nilesh, the data is to be justified. Belgiti had bleeds and deaths in patients who earlier had hepaticojejunostomy. If you see in the first instance you do a hepatectomy, the complications are lesser.
Yeah,
Patients
sure,
who have
but
previous
you need to
HJ,
have
then
adequate
you do
left lobe
hepatectomy.
volume. I think that's important to just
You do
say
a
that.
portal vein embolization,
Yes, exactly.
increase it and
So,
do it.
yeah, I'm saying that you should do an embolization and do a left upfront.
Okay, this is Kolkata, so, good.
So at least only for type 4, at least for every patient going for right hepatectomy.
Okay, TD, I'm going to stop, and I'm going to request the organizers to give us 5 more minutes, because there is a video TD has sent us all the way from Chandigarh. I'm saying as if it's come all the way from some other country, but this is a recent case, and I want to try and play it. So this is a SILS TD, right? This
Yes,
is
it
a
was a
SILS.
SILS, yeah.
So this is a SILS. I will, so here's the SILS starting. So you see that duct there. So we can start talking about there is no window, there's a duct there, there's bile coming up, and then should I fast forward it? Because, okay, so there's a nice vessel coming up there. TD, what is this?
So I thought it is a common hepatic artery because it has come down. If you see that common bile duct is already gone, so that particular area, no?
Okay, so SILS, is SILS more prone to this? I'm being provocative. Is SILS more prone to these kind of injuries?
So Dr.
Is SILS a
Sanjay,
fashion? Should it be banned?
SILS as such doesn't follow the basic principle of getting a CVS. So critical view you cannot achieve with the SILS. So that is the biggest compromise.
Strasbourg has already buried SILS.
But people are still doing SILS, so that's why I'm raising
3
it.
years back, he has written a paper in Annals.
No, sure. We know the papers. I'm saying, what is the view?
It is medico-legally unacceptable to do SILS anymore.
So you are saying we should probably be banned even?
Yes, I think SILS should be banned.
Okay, SILS should be banned. Okay. So, any views? We want to take views. Yeah.
SILS is now branded as some idiots doing laparoscopic surgery.
Okay. So I am not saying that, but okay. So it goes on. So he's divided the artery, he's divided the main duct, and then he goes on to divide the left duct. Now, see, this video is I think important for one reason, because there's no window, etc. So this is actually prevention. At the end, he's divided the left duct. So what do you do now?
So
yeah, 3 more minutes. 3 more minutes.
So
Sanjay, 3 more minutes. Sanjay, 3 more minutes. What do you do now? TD, what did you do?
no, gallbladder has been taken out.
Okay.
I know what did we do. So the
Small
question
mercies,
is,
gallbladder has been taken out. Thank you.
It is something which is known to me, so I think I am not the best person to answer this.
Okay.
Obviously, Dr. Chaudhary will do right hepatectomy. We did a multiple drain.
No, I am asking whether on table you will repair the
on
artery.
table, no, not at all.
Artery, somebody
I
will
cannot dare to repair this.
No, hold on. If you are called in this operation, he has divided the main artery, divided the main duct, why would you not repair the artery?
No, but on table artery repair, you are saying, the question is if somebody is, first of all, are we ready to repair this bile duct at this particular time? Artery, if
somebody has divided the main hepatic artery, I thought there is no choice but to...
Transplant surgeon, if available, if he can use these 6 or 7 vascular sutures, can repair the artery, one can avoid the chances of little bit.
I think if it's a tertiary care center, something has happened, might not happen, but then why not repair the artery?
Okay.
Lot of transplant.
That what I was saying.
I think repairing the bile duct should be done at that stage.
Okay, yeah.
So we'll repair the artery. So
what I said,
you did one second.
Yeah, we'll repair the artery. Yeah. And I think there is data actually. If the vascular injury is detected early and you repair, then there can be long-term result will be better actually. Whenever you do the bile duct reconstruction.
What I was saying that bile duct can be repaired if expertise available. Hepatic artery, but not the bile duct at the same time. This is what I
Not the bile duct at the same time. If you are opening the patient, repairing the artery, the bile duct is next to you.
Bile duct, we will put some drains and tell
why not? If an HPB surgeon is available, see you resect it for CA gallbladders and you repair a small size duct.
So if you are able to repair the artery, you are likely to be able to do
We'll just do a hepatic vaginostomy at the same time.
What if artery thrombosis? Hepatic artery gets thrombosed in the post-op.
So even if
nothing will happen.
Even if it is thrombosed, I will actually make an attempt to repair the artery. If I'm called on the table that artery has been clipped,
but
I'll
since
go
you
and
have got
repair the
up,
artery.
Vinendra, this I just want to ask you. So this is an artery which is going to be crushed. So you would want some length.
Yeah.
So how do you get?
So there are multiple options actually here. So one is obviously you mobilize and you try and get the length. So you can go down and actually, you can get good length into the hepatic artery. It's not like you can't get lengths. And then there is always possibilities of putting an interposition graft.
Okay.
So you can
if you have the backup. Now I had a slide which the organizers are constantly taking off. It's a hint to me that I should stop. This is Dr. Vinay Kapoor's paper, and I think it's a paper that everybody should read, which is bile duct injury during cholecystectomy, culpable or unintentional choledococide. He calls it a choledococide. And he gives a list of, that slide is not there, of how he has judged whether it is a error or it is negligence. He has given 10 factors because he has apparently given opinions in many cases in court. So I think it's an important slide that I wanted to share, and I will not. It's showing up. Okay. So I mean just to say that basically what he's saying is that do the right thing, explain to the family, transfer at the right time. If you transfer, go with the patient or talk to the surgeon whom you are transferring to. Honest communication. Arrange for the bed at the other end. Don't put the patient in an ambulance and say go now or something like that. So I think these are all common sense points, but he's put it down as a list, and I thought it's important to share. Sorry, Sanjay, for exceeding time by 5-10 minutes. Thank you for your attention.